good either morning or afternoon, where everyone is. My name is Armin Jewell. I'm a neurologist and epileptologist in Minneapolis, Minnesota. And I'm here today to present this webinar on point-of-care EEG in the ICU as well as other settings. Wanted to thank the Neurocritical Care Society for extending an invitation to have me speak, as well as by Zeto to have me speak for the Neurocritical Care Society. I'm happy to be here and talk with everyone today. We'll have opportunity for questions at the end. So please hold on to your questions and we'll be happy to answer if time allows. And other than speaking for Zeto, I have no other disclosures. So we can go ahead and get started. So objectives for today's talk, we're going to describe some background of traditional EEG, just briefly, as well as what point-of-care EEG is and the differences, some reasons for each, and the roles of each. We're going to talk about the utility of both, as well as limitations of point-of-care EEG, and how it's relative to conventional EEG and how it's used. And we'll also look at some future directions of point-of-care EEG, some in the ICU and some otherwise, some applications of it, as well as some areas of new research and technology that's being developed through these EEG companies as well. So briefly, this may be kind of review for a lot of people here, but just want to give a brief background on electroencephalography, or EEG. So this is a recording from the cerebral cortex, recording the electrical activity that comes from the cortex in microvolts. The activity has a lot of different sources. The main ones are these things called E and I PSPs, which are postsynaptic potentials. Those are the major contributors. I'll show a picture in the next slide here, make it a little bit more visual. But the combination of the excitatory and inhibitory electricity essentially creates a field that's enough for it to be picked up by the scalp electrode. And the length of the postsynaptic potentials ends up showing up in the graph of the EEG. Also, there is an inherent rhythmicity inside the brain, both subcortically and cortically, specifically the thalamus can activate certain structures, and certain nuclei have components of the EEG, including the sleep spindles, which I gave an example of, which is a part of stage 2 sleep that we see pretty frequently. And there's also networks throughout the cortex that have rhythmicity properties also, but these are kind of the basics of it. And so this is a kind of a visual regarding the EEG. So you can see the electrode on the surface. There's all these layers that the electricity has to pass through for it to be picked up. And then the green pluses and the black negatives combine together to create a field. And depending on which one is stronger, it either forms a positive or negative deflection on the EEG, as shown at the top. This is just another example that shows even more that there is filtering done by the components between the electrode as well as the intracranial contents, so that the microvolts on the left side by those bars go down in number. So the voltage seen is lower as you go further up out of the scalp, because the scalp, the skull, and the dura mater and other layers filter some of that electricity out. So those electrodes that we use are small metal discs that they put on the scalp by an EEG technologist. There's different versions of a paste that they use, whether it's glue or paste, depending on the length of recording. And this helps decrease the impedance so that you can see the current accurately coming from the brain versus getting resistance from the skin and otherwise the scalp and other potential electrodes. The placement is a standardized thing in the United States. It's the 1020 International System, developed in the 1950s. It's been pretty consistent since then. I'll show a visual of this also on the next slide, but they use measurements from different parts of the scalp and those are specific to each patient that gets the EEG. So that way it's conformed to each patient and not regulated otherwise. And the 1020 system is the only current recommended officially system by the Clinical Neurophysiology Federation. And they recommended 16 channels of recording as a minimum number to show most normal and abnormal patterns. This here is a picture of that 1020 system. And just to give a little bit of information, there's these letters and numbers. So the letters correspond to the location on the scalp. So F frontal, C central, T temporal, P parietal, O occipital. And then there's these measurements between them. So it's percentages between the different electrodes. And just by convention, we have odd numbers as the left side of the brain and even numbers as the right. Just an overview so everyone's on the same page here. And once this recording is on and everything is hooked up, it produces a graph that looks like this. This is one of many different ways to view an EEG. Has different electrodes as you can see on the left side, and it's a voltage graph over time. So its time is going on as you go further on the EEG. And it's this specific one comparing two electrodes at a time to create different channels. There's different versions and different montages you can use, but this is a pretty standard one. So basic background of EEG. So we can kind of get into a little more of why there's this advent to create a point of care EEG. If this is working pretty well, is there a reason for a point of care EEG to be developed? And some of the main limitations that came up were time. So as you can imagine, the number of electrodes, there is a time that just is needed to measure and place accurately, depending on the tech's abilities, of course, but it is still a time requirement. There is cost, certainly, of the EEG tech's time, the EEG electrodes, the EEG recording software, the equipment that is required to bring it in, the electricity, networks, everything like that has a cost. And of course, again, it requires a trained tech to hook up the EEG monitoring equipment, as well as the infrastructure to have it be put into the reading portal, so have EEG techs look at it, as well as physicians to read the EEGs. So these were some reasons that point of care EEG was thought about to start and say, hey, is there another option instead of conventional EEG? Do we have another way to create a way to get EEG for people in a different way? At this point, if Cassie, you're able to pull up the poll, we'll do that. So can everyone see the poll, hopefully? So I'll read it. And basically, the goal is just to get an idea of everyone's familiarity with the EEG and the point of care EEG. So options are to use that your current familiarity with point of care EEG is that you use frequently and understand the use. Use frequently, sometimes know the use, sometimes not. Use infrequently or haven't used at all. We'll give it maybe a minute or so and we'll answer here. So, good mixture of answers here. So 34%, so about 34 and 38%, so pretty equal use EEG, the point of care EEG, and know the indications. Another third haven't used it at all, and kind of a mixture of infrequently or sometimes without knowing the indications. So that's helpful. So we can kind of talk further about some of the known indications as well as some of the newer indications and give a background of point of care EEG. So It was developed to address those limitations that we mentioned in the slide previously. So it's to address and give an EEG information for in general, acute neurologic conditions was the initial reason for development and research in the past. Obviously, that's now has changed and is developed, as we'll talk about during this talk today. That was the initial reason for development. The idea was that there was a reduced electrode array to get the most important information and the most specific data that would help us with acute information that is necessary for treatment. Not to fully replace conventional EEG, but to give this typically reduced electrode array to give the limited DEG data that we need to provide data for treatment. The benefit also with this point of care EEG was that it doesn't require a technician for placement. So training can be done for anyone who gets trained on it. Physicians, nurses, techs, anyone really can do these. So the goal with this is to be more universal and have that availability for everyone to place. They're usually disposable units. So you place the electrodes on the patient, and we'll show some examples of different ones. And then they're disposable. And this started in 2018, so it's not even a decade old. Several different models have been developed, and it's rapidly expanding, certainly. So here's some examples. The initial types of EEG, point of care EEGs that were developed were quote unquote headband EEGs. And as you can kind of see from the displays, it's a headband. So it goes around the front of the forehead, around the side, towards the back. So it involves a certain number of channels. You can see the list of the numbers there. And the goal is that it involves the frontal lobes, the temporal lobes, and the occipital lobes. And reasons for that we'll get into as well, but these are the places that were thought to be the most important. So they developed these headbands, and as you might imagine, is relatively easy to place compared to a traditional EEG. Another type that specifically Zeto developed also is this head cap, so another point of care version. However, it is a full coverage cap, so they're able to place the electrodes along the surface, and I'll actually have a video showing how it's placed. So you can get an idea of someone who places it and what it looks like. Those are just different examples of different versions of the point of care EEG that we see and what they look like. I'm going to try and do this video. Let's see. I don't believe there's any sound. So you can see it's a cap that comes out of the box. These electrodes are what she's showing, and they just snap into the device. He is prepping the skull and the scalp and the surface, and then it's put on kind of just like a cap from the front to the back, attached to the patient, and then it's twisted side to side to get good contact with the skin. That is a ground and reference electrodes, and then it's plugged in, and it's hooked up to this monitor. That's kind of a way that it looks at the EEG quickly. So as you can imagine, this was a little bit of a time lapse, but it's showing how it's going, shows how the contact is on the scalp, if there's any adjustments that need to be made based on what is there. You need to readjust or re-twist things on, and then it gives a live EEG on the side of it there. This then, as it's hooked up to the internet, it's beams live to a portal where physicians can read it. So they can give warnings if it's needed, and it's transportable as it's showing the thing can hook onto the bedside. And this is showing a physician logging in and looking at it in real time. That's the idea behind the device, is that it can be hooked up quickly, turned on quickly, and given information quickly. And that's kind of the goal with all of these point of care technologies. So just as I showed the graph before of a traditional EEG, just wanted to show some examples of what point of care EEG looks like. So in the upper left is the limited headband montage that you would see. And so you see there's 8 channels specifically, and it shows the temporal chain around the side on each side. This is compared to, again, a standard EEG on the upper right side. And what you might imagine is that, again, you're missing some of those chains on the top of the head, and some of the issue that there was, or some of the worry that we might be missing some information, they chose to do the temporal leads to ensure getting the most informative data. So there's in the bottom left these missing electrodes here that aren't available with the point of care limited EEG. And then this, again, point of care full EEG montage does include the parasagittal and scalp covering the whole surface of the skull. So it has those electrodes within it in the point of care technology there. Just some comparisons there. These devices all have at this point, different versions, but they all have an AI seizure detection algorithm. So I'll show some examples of those. And this is something that is useful because it has something at the bedside. So this is the screen, different screens for different companies, but they have the screen put on the patient's bedside. And so if it detects continuous seizures or status epilepticus, it will alert based on what the algorithm says to the bedside staff there to say, hey, look, there's something urgent, important to contact the reading physician and make sure that this is truly status epilepticus or not. But it's an important bedside tool that can help get information quickly to treating the treatment team. So this is one example of a headband EEG, and it's at the bottom is where that seizure burden is what they call, or the AI software that looks at the amount of seizures. And when the seizure burden gets extremely high, it goes from 0% to 100%, it's suspecting continuous seizures. In this case, is true, these are continuous seizures. And so this would alert on the monitor, and that's how the algorithm works. And then as something potentially happened or got treated, this on the bottom, the line goes down to a green instead of orange. And that means that there is no seizures detected based on the algorithm. Similar idea for the Zeto full head point of care technology. So this also on the bottom has that same seizure burden marker there, green showing no seizure burden, and then later on potentially some seizure burden as it gets into the orange. And then again, it gives a percentage chance of there being continuous seizures or a percentage of seizures. And on the right, also there are different analysis tools that they have, including the frequency bands and the AI EEG and things like that on the side. But there's different versions of AI that are used to help with bedside analysis. And again, of course, as I mentioned in the last slide, human oversight is important, and AI is a tool to help us, but needs physician oversight to ensure it is truly status versus not. So I won't go through this whole table, but just want to show that there are several different point of care EEG technologies out there. And this is a list of just 7 of them, and there's more in the process of being developed. So these are some, and there's different versions of them, different amounts of electrodes for each, different positives and negatives to each. I just want to show that this is, even since 2018, pretty rapidly expanding, and there's numerous of them that are coming out. So we're going to go through point of care EEG now. So why should we choose point of care EEG? What's the reason for it? What is the process that says, hey, I wanted to choose a point of care EEG over a standard conventional EEG? So some of the similar reasons that we talked about as limitations for the conventional EEG are the reasons for point of care EEG. So again, time to place, seems like it would be shorter, given what we saw in the video also. In general, the cost is less because it has less infrastructure needed. There is, of course, disposable devices, but it doesn't need time for a tech. It doesn't need dedicated EEG machines. So the infrastructure is also smaller. And the idea is potentially more rapid clinical management. If we're able to get data from that point of care EEG faster, we're able to treat them more accurately and more quickly. So this seems like all very good things, but is this actually true? So there are some studies that we looked at to try to figure out, is this true that these reasons are accurate to have point of care EEG as a technology? So for time to place, there's a review article that went through a bunch of different sites that had point of care EEG time to start monitoring versus conventional EEG. And so the left numbers are all the point of care EEG start to monitor, and the right ones are all the conventional EEG. You can see that just in general, while the numbers are varied between different sites, the time to place to start monitoring is less on the point of care EEG side versus the conventional EEG side. So that's a important thing to say, hey, well, if it's 5 minutes versus 239 minutes, for example, and the patient has seizures, it's theoretically should make a huge difference in their care if we're able to see seizures. We'll give some numbers on that as well, if that's also an important part. Next, the cost. So cost savings, while there are, of course, costs associated with new technologies, there was a cohort study in 2023 that looked at these patients to look at point of care EEG to see if it would help with cost. And in general, with that one study, they showed almost 11 less transfers per year. So that was a significant number of less transfers. And by transfers, these transfers, what they were mentioning were people who were needing to transfer the patient to a more tertiary hospital for conventional EEG, and they were able to not transfer them with point of care EEG at their hospital site. So they were able to reduce the costs of the loss of these in transfer, as well as save money annually. And then length of stay is also an important part of cost. And the multiple studies that show that there is a decrease in length of stay. 7.4 to 6.1 was the averages, and in general on the ICU side, at least half a day less length of stay, depending on the scenario. So there was a decrease in the length of stay for them using point of care EEG. And then, as I mentioned before, does monitoring quickly help with management? So sometimes it does. You would anticipate that if you are monitoring more rapidly, quicker to see the abnormalities if they're there, you'd be able to treat faster. And that is what they saw in this study, that they showed treatment escalation occurred more frequently when there was abnormalities on the rapid EEG or point of care EEG versus when they didn't see epileptiform activity on the EEG. And similarly, they frequently or more frequently avoided treatment escalation when there's suspicion of seizures based on the EEG. So they were able to see potentially that there wasn't seizures in a suspected case of seizures, and they didn't need to escalate further, potentially leading to more length of stay, etc. So those are some of the reasons for why. So now the question comes to when. So when do you choose it? So is it every patient that you see, or what's the main reasons for point of care EEG? And I know I mentioned earlier that the original reason for point of care EEG was for acute neurologic changes, and that is still a vast part of it. However, there are different other sources and uses for this that we'll go through. So I want to bring a case to kind of give an example of a typical time where you might consider point of care EEG. So this is a 67-year-old female, right hemispheric stroke a year prior, and came to the ED with unresponsiveness. So your CT head that you looked at, no changes. Quick lab work done, didn't show anything obvious as a reason for the unresponsiveness. And in the weeks prior, there had been some worsening of the patient's chronic weakness and speech changes, and there was not prior seizure history. So in this scenario with an unresponsiveness like this, there is, of course, sometimes a concern for a prior neurologic injury causing ongoing seizures. And so this is a common reason or common use of this, especially in emergency departments, for placing the EEG on to see if there is ongoing seizures. So different reasons now that we'll go through for point of care EEG that have been developed. The main one is going to be in this top right here. So that's what we just were mentioning, is ruling out NCS or NCSE, which is non-convulsive status epilepticus. That was kind of how it was originally developed to rule out these cases of basically ongoing status epilepticus versus not. And there are different studies that look at that, and we'll go through those more. The other parts of this, and we'll go through all these individually, but the other parts of it include TBI, delirium, post-cardiac arrest in acute settings, like we mentioned before, as well as in stroke, diagnosis and prognosis. And just so that we're all on the same page, the definitions that they used in these studies for non-convulsive status epilepticus is the typical ILAE definitions and ACNS definitions for status epilepticus. I won't go through this table, but just so that we're all on the same page about the definitions that were used. And so for non-convulsive status epilepticus, in a study retrospectively, 14% of the ED patients coming in with an acute neurologic injury ended up having non-convulsive status epilepticus, and that was using a point of care EEG technology to look at those patients. The reason to look for these patients is for two reasons. If there's an acute neurologic injury, one, if there is a high suspicion for seizures, then you can use it to confirm that there is continued seizures, truly, or in a lot of cases, potentially similarly to the case that I just presented, excluding seizures in an altered mental status situation with unknown reasons, particularly higher in patients with an old or prior neurologic injury. So the specificity of this, and that's these numbers down below, the specificity of this is high. The accuracy is high to rule these things in or out, as mentioned above. There are occasionally false positives and false negatives. So those are also always part of different tests, of course. And we'll go through some of those and what the reasons for those would be. But this is a reason to use, a common reason to use point of care. The stroke is another reason to use point of care EEG. Some review papers and studies looked at the role of point of care EEG with acute stroke, and they determined that it may play a role in some cases and sometimes not. So essentially, sometimes people coming in with stroke do also have concurrent seizures and require treatment for those seizures, and it's not always clear based on their symptoms. And especially negative symptoms versus positive symptoms are tougher to determine often whether these are related to seizures versus the ongoing stroke or prior stroke. And this is a common mimic, and some studies estimate up to 20% that we're seeing that these are actually a seizure phenomenon instead of a vascular phenomenon or structural phenomenon. And that's a thing that the point of care EEG can be used to, in the right clinical setting, to kind of rule in or out. Is there also seizures happening as a result of potentially fluctuating symptoms or other things that would cause similar things to stroke? So the TBI part of it is a little bit newer on the end of point of care EEG, so more information and data needs to be obtained regarding this, but in general, TBI has had some studies showing that continuous EEG just in general does have a useful prognosis importance for it as an adjunctive tool in moderate to severe TBI. And so if that is the case also, then potentially there's a couple of thoughts that either they can use it as an initial TBI assessment tool or from an outcome prediction standpoint. And this actually came into a study just recently done in 2024 called the FIRE study. So they actually had EMS workers and EMS trained people using these point of care technologies. So they had the technology in the ambulance with them. And if there was a suspicion of a TBI, their study asked them to place the point of care EEG and decided based on the severity of the point of care EEG data what to do with the patient. Is it needed to escalate to a higher level of care or a lower level of care? And it made some difference on decisions for where they went. One question, of course, that may come up is this technology able to be placed by EMS? Is this something that can be trained and done? And 84% of the time it was an adequate quality study. So it seems like it was something that was able to be successfully placed. So this was an interesting early on study for different uses of point of care EEG, even outside the hospital, to determine do they need to come right to a high level trauma center or not. Delirium is also one of the newer reasons for it, using point of care EEG. There was some prior work before using point of care EEG looking at bispectral EEG, which is basically a two-channel EEG to try to show is this delirium or not delirium in patients in the ICU specifically. The criteria from an EEG standpoint had basically further slowing on an EEG. So more delta, reduced alpha, disrupted posterior dominant rhythm, other things including the AP gradient that was lost, lack of reactivity, things like that ended up showing up as more likely delirium. And so because of these earlier studies, they did a single channel point of care EEG test and to see would this give a higher sensitivity of picking up delirium amongst patients. And it said basically, yes, that there is a higher chance of finding delirium in these patients and that the EEG data tended to outperform the screening tools that we use as clinicians at the bedside. And there was recently an approved delirium algorithm that's starting to be developed as well, using a study of over 200 critically ill patients to determine delirium in patients as well. So this is kind of a new emerging component of point of care EEG technology to adequately treat and determine delirium in ICU patients. Lastly, post-cardiac arrest. So this is a relatively, for most people who are aware, especially in the Neurocritical Care Society, certainly that EEG and post-cardiac arrest care is a significant and important component of the treatment strategy and prognostic value for it. And so you might imagine if conventional and continuous EEG does have prognostic value that point of care EEG would also. The part that became an issue with the point of care studies was mainly artifact related. As you may imagine, in the ICU, there's a lot of different electrical tools and things that are there that can limit some interpretation. And so in some of these studies, there is even a limited interpretation because of the artifact. We're going to get into some of the limitations of point of care EEG also, and that's one of them is the artifact. And specifically in the ICU, it did have quite a bit of artifact that potentially led to limited interpretation versus conventional EEG. But again, similarly, in the last point there that I made is that if this is what is available in hospitals without access to continuous EEG, there is still some value that even among the patients that they screened with point of care EEG, they did show some post-arrest seizures, so that helped modify their treatment plan. This again, the summary that we went through these 6 different components of it that are currently the main uses for point of care EEG. Some well established, some more on the up and coming side, but kind of shows that there is use in different ways for point of care EEG. So while point of care EEG has some utility, of course, that we're seeing, what are the limitations? So not everything, of course, has everything perfect for it. So we need to go through what is the downsides of point of care EEG. So as we talked about before, some of the technologies are a temporal chain only. So this, what you may worry about is parasagittal or seizures coming from the electrodes that are there on conventional EEG, as well as and not on the point of care EEG. So this was looked at, and it kind of made sense that they wanted to look through this, and there were some false negative cases that it was few, but there were some small cases of seizures that weren't seen on the point of care EEG because it was the temporal chain only, and it was limited to the parasagittal seizures. And how common is this? So there's a group at Stanford that looked at this, 300 patients that had seizures on EEG. Of the 17 that they found that had seizures on EEG, 2 had parasagittal midline seizures only, so 2 out of 17. All of those 2, none of them had absence of abnormal activity on the temporal chains. So it was thought to be either based on clinical suspicion or based on some spread to the other channels that this was still seen. However, there is, of course, the theoretical side that you may miss parasagittal seizures. This is an example of seizures kind of right in the B area that you can see there are seizures coming from that parasagittal area only. So this is a possibility. Based on our studies so far, which are limited, of course, it is rare that this is the case, but it does tend to favor having more full coverage in those cases. They often also tended to base it on clinical suspicion. Parasagittal related seizures, for the most part, or tend to often have motor symptoms related to them based on anatomy. So if there's clinical suspicion for motor related events that are seizures, they tended to say, well, you should favor a full coverage EEG of some kind. Other limitations include the detection algorithms. So AI, of course, has its place, and it does have a utility as a tool to combine with physician interpretation. The detection algorithms tend to favor seizure burden instead of isolated or brief events. So essentially what it looks at is frequency of seizures and seizures happening. So less sensitive for detecting things like interictal discharges or very infrequent seizures. And that is higher sensitivity and specificity with conventional EEG. So while the AI and the software is great as a screening tool and a tool, it still needs that physician to look at the data to make sure that we're not missing intermittent seizures or well-performed activity. And so another other limitations that we can see is that there are sometimes point of care EEG interpretations that may or may not be fully accurate. And again, we talked a little bit before about artifact as a potential reason, and that some of these times where we see abnormalities on a point of care EEG, it's not entirely clear, is this truly an EEG cortex-related abnormality or an artifactual abnormality. And given its ambiguity, occasionally this leads to sometimes over-treatment. And that's one of the limitations that was mentioned in a few articles. Sometimes it's used in suboptimal cases. So in patients who are awake and otherwise feeling okay, a traditional headband EEG, for example, is a good starting point, but it needs a full EEG to fully assess the cortex, as well as often in awake patients, there's a lot more artifact and things that are tough to interpret. And as I mentioned before with the temporal chain, headband for movement-related issues is headband point-of-care EEG for movement-related abnormalities is not as sensitive because it's missing those parasagittal inflows. So false negative results with the AI. So there are some where there have found in both cardiac arrest patients, for example, with this one study, that there were some that had status epilepticus and that wasn't picked up on AI. So again, just knowing the limitations of AI is important. And then false positive results as well. Largely, again, these are related to artifact. So that there were some times that it was tough to tell. In this one study, there was false positive status epilepticus, which led to earlier treatment than was necessary. Conventional EEG was then eventually placed and ruled it out and was able to de-escalate treatment at that point. So these are, again, some limitations for the point of care EEG. All right. So in kind of summary a little bit, so some takeaways for clinicians for point of care EEG. So I'll just briefly go through these just as this is a kind of a good summary for all the things we've mentioned. So point of care EEG important and enables rapid detection of non-convulsive status epilepticus and high seizure burden. So as we talked about a few times, if ongoing seizures, it's quick to set up, so you're able to see if there's ongoing continuous seizures pretty frequently. And it's best for detecting really sustained activity. So again, lower sensitivity for those focal or brief events or interictal discharges, not as sensitive. We have also mentioned before, parasagittal seizures or low burden seizures, again, may be missed because it does not definitively exclude seizures. But again, it's a triage tool and not a replacement. So this is why it's important to know the limitations and the strengths of using the point of care EEG. AI, of course, as I mentioned, has very good use as a tool and quick to assess and needs to be interpreted in the right context as well as with physician interpretation. Point of care EEG in underutilized and under resource limited hospitals is particularly useful. And that's shown in a couple of different slides, but that if there's no access to EEG or continuous EEG, then this is a good useful tool to sometimes screen and avoid transfers, as I mentioned earlier also. Artifact is a common part with both types of EEG, but as well as this EEG technology. And early application of this can prompt meaningful treatment changes. As I mentioned, if you're able to see ongoing seizures quickly, then you're able to treat quicker. There were certain EEG patterns that are detected as well with continuous and point of care EEG, especially when it is something that can be placed for a long term. So for post-cardiac arrest, prognosis, et cetera. And the physician review is important. So lastly, so future directions. There's multiple different areas that point of care technology is going. Part of it with the AI platforms and how to early detect accurately status and seizure burden. And that's ongoing with different types of things through both Zeto as well as others that are trying to develop a way to accurately link the AI technology with a quick clinical interpretation to get an accurate diagnosis quickly to the treating clinicians. Treating and determining epileptic versus non-epileptic seizures is a kind of a different thing we didn't really talk much about. This technology isn't really at this point used much in these cases, as conventional EEG is typically more useful for these types of patients. But they need to do more studies looking at the difference and seeing as point of care EEG a reasonable strategy to start screening for these different types of seizures. Briefly mentioned that study that did the pre-hospital setting EMS utility. While they looked at it mainly for TBI, could they use it for an early unresponsive patient potentially with ongoing seizures at home, and even give anti-seizure medication if informed correctly in the field, and even treat seizures sooner. And then the workflows just to implement these point of care EEGs, since it is a relatively newer technology, there is just some workflow that would be important to develop that's clear amongst different sites. Right. And so with that, I want to thank everyone. There's some references that I can have listed for you later, but I'm happy to answer any questions. Thanks to everyone for listening. Thanks again, New York Critical Care Society, for inviting me, and for Zetto for inviting me to speak. And happy to answer any questions, and any feedback is appreciated.
Hi, Greg Capinos. I have a question for you.
Yes, go ahead.
Excellent presentation. I love the way you organized all those different topics on the utility of all those point of care EEGs. Something you did not cover much, and I want you to tell us like what is in the pipeline in all those different devices with those different companies in terms of a more quantitative EEG. So outside of seizure detection and even outside of delirium detection, is there any efforts that you're aware of to really fully leverage also those REDs in terms of an analysis of the background and doing quantitative EEG for other things, like you briefly mentioned trauma and hypoxic injury, neuroprognostication, but yeah, what do you think is the future of REDs in terms of background analysis and quantitative EEG?
Yes, good question. So I actually believe I had a slide earlier that showed a little bit of it, but at least at this point, the Zetto group does incorporate Fourier transforms and quantitative EEG into their EEG software. And so whenever an EEG is placed, they have the graphs of those things, the quantitative EEG, the amplitude integrated EEG, things like that are listed there. So that is part of their package that they have. And as far as things in the pipeline, they are looking towards specifically with Zetto. I know they've mentioned there's a way to more accurately get an accurate read for early EEG changes to clinicians. And what they're planning to do is to have the AI software read the initial EEG, have it, and it's being piloted currently and happening currently in some sites. Will read the EEG, and if it gives a high seizure burden, they've partnered with a company to have a tech also screen. So a live person, an EEG tech, will screen the EEG as well. And if they also agree, they will then alert the physician to say, hey, there's 2 points of information that are thinking these are seizures. Please look at this more closely and give the final word on it. So those are some of the things in the pipeline, as well as just further accuracy as far as the technologies. So there's different AI for each company. And even as point of care has developed over the last 5+ years, the technologies that they use are tending to try to get those less obvious seizures or less frequent seizures that are often or sometimes missed that I mentioned earlier. Hope that answered your question.
Yeah, excellent. Did I understand correctly that Ensevis, or the German software that is sort of a competitor to Persist, is working with Zido, or are they
Correct.
applying to? Yes?
Yes, that's correct. Yep.
Oh, okay, great.
I see another hand raised. Feel free.
Um, Thank you for this excellent presentation. Quick question: are there any limitations as to the duration that these point of care EEGs can be used for? Um, and if you could elaborate with the current examples we have in the United States, Cerebral, for example, or the Zito, for example, with regards to the FDA clearance that these devices have, and for what duration are they cleared for? Thank you.
Yes, good question. So the Cerebral current approval and the general use that I have seen as the most common use is for acute settings. So acute ruling out of status epilepticus, ER visits, etc. The Zeto technology, as it involves both a full head montage as well as video, is being used in much longer settings, 24 hours plus, and can be used in the ICU, etc., for monitoring in that case. So the differences are there for those reasons, basically, with the amount of coverage with the EEG as well as the video availability. Obviously, there are things in the pipeline for every company for adjusting these, but those are the main, uh, some of the limitations based on just technology, as well as some of it is battery related. But overall, those are the kind of the typical uses from a headband EEG versus a full point of care EEG.
When you say battery related, do you mean both the cerebral and the examples that we are talking about? Both these examples, they since they're battery operated, so there could be that logistic, limitation on the time frame that they can be used for. Is that correct?
Correct. Yep. So it would limit it, but there's often ways that it's mitigated by having separate device being ready to hook up or having a backup battery to switch in batteries, etc.
Gotcha. Is there any FDA regulatory data regarding either of these?
The battery life.
Well, just in general, the duration of use and approvals for being used in different clinical settings.
So as far as I'm aware, the Cerebell is again approved for the 1 to 2 hour length time. I'm not sure if there's an exact number that's FDA approved, to be honest, but I know that they're both technologies are approved for that length of time. And the Zeto is approved for longer monitoring because of its full coverage.
Thank you.
I can add to that if you don't mind. I would say that yeah, it doesn't really matter what the FDA, and I'm pretty sure, yes, Ceribell did not shoot themselves in the foot by requesting only a 1 to 2 hour FDA label. Obviously, you can run it longer. We frequently run it longer than that, but I prefer to restrict it to 1 to 2 hours to avoid pressure ulcers in immobile patients that have a frail skin. Um, yeah, as you said, Zido, obviously it's approved for even longer because the intention was to do it as an outpatient, to give it to the patient to do a home study, basically. But I would say that the recorder's battery is never to me an issue. I have more issues with degradation over a few hours of the quality of the signal because of the patients are moving and or the leads are moving on the scalp, and obviously, a restless patient will degrade its study even within 30 minutes, or even rip off the, the headband before the battery comes to an issue. So to answer the question of the of Dr. Gopal, you never have an issue with the FDA or the recorder. You have more issues with movements of your of the head that will disrupt the quality of your signals. And one technology that is even worse is actually the strips that are applied. I would say like the stat nets connecting to the micro EEG. Although the quality of the micro EEG is great, the problem is the stat net. Those little sponges on the skin can frequently move, and I feel like after 6 hours, I never have a good quality study. And the rhythm link press-on electrodes, those little prongs in the epidermis, are also falling out frequently. So even if you have a full montage, after 6 hours, I end up with 25% of my leads are that have fallen off. So in practicality, to answer your questions, you should never plan on using a rapid EEG for more than a couple hours, especially if you're trying to rule out status epilepticus. But Zido, yeah, was intended for outpatient overnight.
Okay, thank you so much.
Great summary, thank you.
Hello, if I may. I'm a student still, and I'm currently
Vector is
taking
what?
ENLS. I was wondering if you can use POC EEG if you are getting to tier 3 of management of an ICP crisis and you're trying to titrate your sedation to burst suppression. Um, yeah, would you be able to use a POC for that, or would it be more of just strictly full continuous EEG?
That's a good question. So some studies that have looked at the sensitivity of the point of care EEG and its ability to pick up things like burst suppression and immunosuppression. So far, the studies look pretty good that there isn't that much data on it currently. Um, but the studies look pretty good that it is relatively the same or similar to conventional EEG as long as it is a full coverage point of care EEG. Um, and so far, it looks like it can be used, but it's still limited data at this point.
I see. So that's full coverage, as in, not like a Cerebell where it's just that limited
Correct.
selection of leads. Okay, thank you.
Well, can I push back against that? Like have a debate with you, with the presenter, Dr. Jewel, because actually, yes, you're correct that obviously we prefer a full montage. Ceribell is coming up with a full montage, a second, by the way, headband that you can put under the jaw and does cover the vertex. But to me, actually, simpler is better. And to me, deploying a full montage or deploying even worse, an EEG tech at the bedside when it's been the third day that the patient is in burst suppression pattern, it makes zero sense. I would actually answer to the student that it's actually an indication. Sometimes I'm bored with my full montage EEG and I would prefer we use a Ceribell as a spot check because let's say the pentobarb that I'm using anyway, when I change the dose, I'm not expecting a change in my burst suppression pattern for a few hours. So spot checking with a Ceribell or a very limited montage to me is great for burst suppression pattern because it's such a radical, like you don't need the finesse of a full montage on NADAS to detect what is burst suppression pattern in especially for ICP control as the student was mentioning. But I welcome your feedback.
No, yeah, that makes sense. I think if it was, I agree, especially as a spot EEG check, that's a great, I would say that I would agree that would be a great use. The long-term monitoring, again, I would always tend to prefer full, whether it is the upcoming fuller montages with Cerebell or otherwise. But if it's a spot check, I agree something like a headband would be reasonable.
Fascinating. Thank you so much.
We are at the 1 o'clock mark. Certainly, everyone who still has questions, feel free to let me know, or happy to answer any questions. Just for sake of time, we'll finish up here. But thanks everyone for coming and listening, and hope you have a good rest of your day, and take care.